Okie dokie. Going live. Okay. Welcome back, everyone, to round 2 of Morgan Takes on Technology on the PT on Ice Daily Show. What a great way to start your Tuesday. Apologies for that little technical difficulty. There's been a windstorm here all night, so the internet's a little bit spotty. So apologies if I cut out. I think I found a good spot this time. So, again, good morning, everyone. For those of you who don't know, my name is Morgan Denny. I am lead faculty for the Institute of Clinical Excellence, and this is the PT on Ice Daily Show. I teach the primary care physical therapy course as well as the post-COVID management of the patient. So, today I really wanted to talk a little bit about rheumatology. Now, this is a weird one, right? It's not something we think about very often, but often, like in the clinic, how often is it that a patient comes in that's kind of complicated, that says, I'm here for shoulder pain? And then when you start asking about other signs, other symptoms, other limbs involved, they give you that look that says, how long do you have? Like, how long is this appointment? I can't go through the laundry list of symptoms or injuries that I've had in our amount of time. I really just want to focus on my shoulder, my knee, whatever. But sometimes when people have a variety of symptoms or have had a lot of injuries, it can point to something that's more underlying, an inflammatory condition, something that's autoimmune. But I think sometimes it's really hard to tell when we need to say, let's stop care and I need to refer you somewhere else. So today I wanted to talk a little bit about what that looks like and some common things to look for that might like raise our spidey sense and make us think, oh yeah, this person maybe needs to be screened by someone else just to make sure there's not something going on that's systemic, that's basically thwarting our care or their ability to get better or heal. So let's talk through the factors a little bit first. So one of the factors that really should increase your spidey sense or start getting the buzzers going in your head is when someone comes in and they've had a lot of injuries, right? Just multiple. Now, let's be real. Like, if you're an active human in life and you're over 20, you probably have sustained a lot of injuries. So you've got to parcel through those, right? But when you've got your body chart, that checklist where you're going through and saying, okay, now any symptoms in the knees, anything in the ankles, what about the feet, any history of arm problems, anything in the neck. If someone stops at every body region and is like, well, yeah, this happened, this happened, this happened, that to me is something that should make us think like either there's something going on where this person is injuring themselves, a systemic training pattern that's poor, or there could be something else going on. Now, the other thing to think about there is many people will have a lot of injuries just from being active, but if you dig into what kind of injuries, that gives you another hint about whether it's something you need to dig more into. So, for example, injuries that are more traumatic or have a obvious cause, like, oh, I ran up this really steep hill that I'd never run before, and then my knees started hurting. Okay, you added something to your training, your body wasn't used to it, and you had a breakdown. You weren't strong enough for it. Or, like I had a fall, I sprained my ankle. You did something that had an obvious cause. Like for me, I mean, I'm totally one of these people that if you ask me about prior injuries, I'd be like, we don't have time for this. But a lot of my injuries have come from activity. So they're obvious. Like I tried to move in climbing and I didn't do it well, hurt my shoulder. Or, had a fall in soccer, hurt something else. Something like that. That's what we're looking for, an obvious cause. When injuries all seem to be idiopathic for this person, so they kind of come on with no rhyme or reason, there's no change in training pattern, no change in, other lifestyle factors, no change in activity. It's just my shoulders started hurting, my knees started hurting, no change, no shoe change, no anything. That should start to raise our level of like, the sixth sense that tells us like something else is going on here. So that's number one, multiple injuries and that are idiopathic in nature versus traumatic. Also, thinking about whether or not they've fully healed. So, a lot of people will kind of have those injuries that stay sort of just below the surface, and they do something, they run a little bit farther or bike a little further, and then that injury comes out and they come to see you. If that's living below the surface, it's not fully healed. The patient that comes in, they're like, I broke this, sprained this, whatever, it's never caused me a problem since it healed. That's a great sign. But the people who are like, yeah, it kind of flares up now and then, but it's okay. I don't want to talk about that today. That again should be something that makes you think like, is there something else going on? Is there a reason, a cause inhibiting this person's ability to fully heal that injury? So the next thing to think about is, are all of the injuries a similar type? And what I mean by that is, do all of the injuries involve a similar tissue? So for example, in PT, we're really good at like picking up on bone compromise, right? If someone comes in and we're looking at things and we think this could be a stress fracture, and we look at their previous medical history and we see other stress fractures, that clues us into thinking like, is this a metabolic thing? Is there osteoporosis on board or osteopenia? Is this a training problem? Is this, if it's a female, is there something going on where they're not getting enough calories or rest or overtraining, et cetera, et cetera? We're good at keying into that. But are we as good at cluing into when someone comes in and all of the injuries they report have a tendon involved? Like there all seem to be tendinopathies. Where are those tendon injuries? Are they mid tendon? Are they distal? Because a lot of different autoimmune conditions will affect the whole system, but they will affect specific tissue. For example, psoriatic arthritis affects where tendon inserts into the bone at that periosteal junction. So people with psoriatic arthritis will often develop plantar fasciitis and patellar tendonitis and triceps tendinopathies, like things all over the board. They all seem to be distal where the tendon attaches into bone. These people also will have other kinds of inflammatory things, but if we're seeing that history of there's all these tendon type of issues and none of them are necessarily traumatic, they all just sort of came on, kind of heal, but won't really go away, that could be a sign that there's something else going on that's systemic. Another kind of like grouping could just be like joint, capsular stuff. If people come in and they have an issue where like their knees and their elbows and their shoulders kind of are achy and seem to be inflamed, but there was no reason, that's not necessarily normal. Like that shouldn't necessarily go like, oh yeah, that's just a thing that you did. No, that's something that we should be picking up on and saying like there's something else going on. So again, thinking about, are all the injuries of a similar type, like a type of tissue in the body? Now, the next thing to think about is, are symptoms bilateral? Now, there are a lot of reasons for bilateral symptoms. I fully recognize that. When you have a patient that comes in that has bilateral symptoms, the first things you should really be thinking, probably beyond a systemic inflammatory condition, are things like, is there a central cause? Like if there are bilateral shoulder or elbow symptoms, is there something in the cervical spine? Is this a developing cervical myelopathy? Same with the lower extremities. Like, is there something central? Because that's a really common cause for bilateral type of symptoms. Additionally, you could think of systemic or outside environmental factors that could affect it. Like, did the person change shoes, and then go for a long run? Okay, it makes sense that they had bilateral foot pain. There was a change to the environment that the body either wasn't ready for or wasn't good for the body. So you'll see that bilateral effect in that case. But again, symptoms don't often, especially idiopathically, develop bilaterally. It's not often that someone just wakes up and suddenly both their ankles hurt. It just doesn't really happen. So we've got to start thinking like, what is going on here? Now, the next thing that I'll throw out there, and this one's a little bit harder because everyone is different, but we've got to think, is the symptom reaction proportionate or excessive to whatever the trauma or the cause was? So people will often attribute their injury to a cause that may or may not be correct. But for example, if someone says, well, I opened a jar yesterday and both of my wrists swelled up like crazy, and they come in and their hands look like balloons. That's really not proportionate to the activity involved, unless this person had an excessive amount of, was very sedentary, like very, very sedentary. And this is the first thing they did out of bed. But thinking about that, thinking about what does an ankle sprain normally look like? When someone comes in with this type of hand, arm, shoulder pain, what does that look like? And then is this person's reaction kind of within those normals, or is it kind of excessive? Because with an autoimmune condition or with something that is an underlying inflammatory condition, you're going to see an excessive reaction to a fairly normal amount of force. And so when people come in and their story doesn't seem to match their symptom presentation, that's another thing that should really, really like turn your spidey sense up. So those are a couple of things to kind of think about. Now, what is it we're really screening for here, right? Like, why would we send someone to a rheumatologist? All of their symptoms seem orthopedic. They should be seeing me or you, a PT. But here's the thing. Rheumatologists are better at screening for some of these underlying conditions like RA or psoriatic arthritis or lupus or all of the many inflammatory autoimmune conditions that can affect the musculoskeletal system. Additionally, good rheumatologists will also know how to screen for like hypermobility syndromes or think of potentially screening for food allergies or environmental allergies. For example, I had a patient a couple of years ago who had a bunch of different like breathing and chest tightness things that we were just talking about, not related necessarily to her case that I was seeing her for. But I ended up sending her somewhere and they did a bunch of environmental screening. Long story short, she ended up changing the insulation in her house and it completely solved all of her respiratory stuff. So sometimes it's not a PT thing. Sometimes it's outside of our realm, but we need a little bit more oversight. Or, for example, I had a different patient who came in and it was 2 days after his injury. His injury was he went on a climbing date with someone. He didn't climb very often, but he didn't do anything crazy. And he had woken up the next day with like swelling in both knees and ankles, and his arms hurt. And when he moved, he looked like an old man. This guy was like 30. So that was an obvious one. That's like, no, this didn't come from just going climbing and now you can barely get out of a chair, even though you were fine 2 days ago. That person actually ended up having a gluten allergy, and after getting gluten out of his diet, was totally fine. But again, these are people showing up to PT that we need to be able to screen through. The patient that I have right now that actually inspired this talk, because I was really thinking through like what my process was, is a patient that came to me a little while ago with multiple injuries. So again, checked that box. He had seen a bunch of different PTs throughout his life, really believes in PT, feels it has a good place, but has bilateral foot, ankle, shin stuff, some shoulder stuff that's off and on and nagging, some back stuff, just kind of a lot of things for being a fairly young and generally healthy person. And honestly, in day one, when I evaluated him, I said to him, like, don't you think it's a little bit odd that even though you're fairly healthy and active, you've had all these injuries and it sounds like they're still all affecting you, even though it sounds like you've addressed them in PT a fair amount of times. He was like, yeah, I've always wondered about that. So that was day one. We still gave it a shot. I didn't refer him right off the bat because at first you're just, you're fact finding, you're exploring, you're seeing what can change. Because it's certainly possible to have people with a lot of injuries who just haven't found the right thing or stuck with it. So we treated a little bit. But what I found was that all of our treatment stuff had fleeting success. So we'd treat something and it would work for a little while, and then we'd add something new, and then it would things would degrade, or something new would pop up from, another activity that seemed fairly normal. So, oh, there we go. Anyway, so at that time, we basically talked about like referral to a rheumatologist. I didn't stop treating him right off the bat because here in Portland right now, referral to a rheumatologist takes about 4 months. Not awesome. But we kind of started digging in a little bit more. So I asked him about any kind of blood test he'd previously had. So he went back through his medical history and kind of looked at that and sent me an email with like his 3 prior blood tests over the past 5 years. All of them had mostly fairly normal readings, but each one had at least 1 or 2 values that were outside the norm that could indicate underlying inflammatory condition going on. No doctor had ever talked to him. Now, I had no idea if that's because he had gone in for other reasons and so had gotten brushed under the radar, or if it was just not as far outside of the normative value to kind of clue someone to start looking or think that this was a problem. But this is something where I went through and I highlighted each thing and I wrote what was wrong with each problem so that he could take it to the new rheumatologist that he's going to see next month and therefore be able to kind of get more information. But I just want to bring up this topic because I think while it's fairly rare that we see someone that does have an undiagnosed underlying autoimmune inflammatory type of syndrome going on, It's not impossible. It's going to happen. I mean, it's going to happen more frequently than you'll see like a VBA, for example, hopefully, knock on wood. Anyway, so just keep in mind those factors. Again, thinking about, does this person have multiple injuries, especially ones that are not healed and seem to be idiopathic in onset? So they don't have a realistic reason that they happened. Are all the injuries similar? So do they affect a similar type of tissue in the body as an autoimmune type of condition would? Now, slight caveat, if someone has really poor lifestyle habits, you can have inflammatory levels that are heightened from that, but it often won't affect a person this dramatically. So again, are all the injuries a similar type of tissue? Next, do they have bilateral involvement that doesn't make any sense? Like there's no reason for it. And have you ruled out central cause from the spine or any environmental change, like change in activity or change in shoes, change in work, change in activity that would make sense to have both extremities involved? And then beyond that, is the symptom reaction excessive for the cause or does it make sense? So these are just some things to think about. So if you have one of those patients that has a ton of things going on where you're just kind of like bopping around, shifting, treating the shoulder, the knee, the ankle, the hip, sometimes just backing up and looking at the full meal deal picture can be really helpful and kind of reassessing, does this patient potentially have something else going on? And if so, can I make the referral to a rheumatologist that can screen for some of these things more appropriately? So I hope that was helpful. I hope you all have a really awesome Tuesday. And again, sorry for the technical difficulty this morning. I will also say the primary care course coming up in March has one spot left. So if you've been jonesing for it, March 21st is when we start. So sign up soon. Okay, everyone. Peace out. Have a great day.